Thank you for joining the third virtual resident education lecture series today. Today's topic is behavioral neurology and neuropsychiatry, and specifically an introduction to dementia. All participants are muted, so if you're having any technical difficulties, we recommend disconnecting from the webinar and reconnecting. You can connect using computer audio or by the dial-in option, and you do not need to use both. If you continue to have technical difficulties, send a message through the chat feature and we will try to assist you. For questions, please use the Q&A feature on Zoom and we will answer them throughout the talk. We have Dr. Daniel Weber, Adult Epilepsy Division Director at St. Louis University School of Medicine, joining us as our Q&A moderator today. Dr. Weber started doing a virtual lecture series at the beginning of the pandemic on his own and now has connected with the AAN to continue this resource for residents. I'm pleased to introduce our speaker for today, Dr. Carolyn Fredericks. Dr. Fredericks is now an assistant professor of neurology at McCance, Yale Scholar at Yale Medical School, where her research focuses on preclinical Alzheimer's disease and on less common Alzheimer's variants, using advanced imaging tools to better understand how Alzheimer's disease progresses through functional networks in the brain. She specializes in the diagnosis and treatment of neurodegenerative disorders. Dr. Fredericks, I will turn it over to you.
Thanks so much, Allison, for the wonderful introduction, and thanks, Dr. Weber, for hosting the series. This is going to be a fairly introductory talk, and so I'd love for all of you to feel free to participate and jump in with questions at any time during the talk. We'll also have some time afterwards for questions. I've made it fairly clinically oriented, but if you have other questions about the pathophysiology, please jump in with those, and if you have questions about the clinical stuff too, of course. So the way that we're going to structure the talk today is we'll talk about, first of all, what dementia is and isn't. I think it's easy for people, especially outside our field, to confuse dementia and delirium in particular. We'll talk about that a little bit. We'll also talk about the issue of clinical versus pathologic diagnoses in dementia. So when we say someone has Alzheimer's disease, are we talking about the clinical syndrome or the pathologic syndrome or both? And in some of our dementia syndromes, this becomes even more complicated. We'll spend most of our time going through the four most common dementia syndromes that I see in my clinical practice. So specifically Alzheimer's disease, vascular dementia, dementia with Lewy bodies, and the behavioral variant of frontotemporal dementia. Of course, there are lots of other dementia syndromes too that are less common, and I'm happy to answer questions about those, but we'll focus on these four for now. So to start off with, let's talk about the formal definition of dementia as defined by McCance and colleagues back in 2011. Essentially, dementia is defined as any cognitive or behavioral symptoms that impact someone's ability to perform their day-to-day activities and that are declined from where they were before. So dementia might mean something different for somebody who has very little education and has never worked outside the home versus somebody who has been working at a very high level and is no longer able to do so. These symptoms can't be explained by delirium or a major psychiatric disorder. And we need to see decline in, at minimum, two major cognitive domains. And that could be memory, executive function, spatial function, language, or their personality and behavior. And for some of our syndromes in particular, as we'll talk about, behavioral changes and psychiatric changes are really a major part of many patients' presentations. You're all familiar to some extent with the cognitive domains, but I wanted to take just a moment at the beginning of the talk to talk about them a little bit more and think about how we assess them at the bedside. I'm sure everyone's seen the MoCA, the Montreal Cognitive Assessment. It's a wonderful, brief 10 or 15-minute cognitive screen. I like it because it gives us a few questions in each of these cognitive domains that I referred to before. And I think many of us are first familiar with the mini mental status exam, which is another very commonly used brief cognitive screen. The MoCA is nice in that it's, first of all, a little harder so that you can appreciate subtle changes more easily in a patient who might have been very high functioning at baseline. It also gives us a lot more to work with in terms of executive function in particular. As you can see, the visual, spatial, and executive domain questions are especially focused at the top. Patients are asked to do a trails task where they switch from number to letter and back and forth. So a set shifting task to copy a cube, to draw a clock and put the time on it. And over the course of the MoCA, we go through aspects of many of these cognitive domains. All that said, you may not have one of these in your pocket as you're walking around the wards, and I think it's important to build your own 5-minute bedside cognitive assessment that asks questions that relate to all of these domains. I think often we're tempted to just check and see if the patient is oriented at a basic level, perhaps if they can follow a two-step command. But it's helpful to try to build yourself a routine that incorporates a little of each of these domains. Mild cognitive impairment, as distinguished from dementia, is another thing we should talk about quickly at the beginning. Very similar to dementia, we're talking about cognitive or behavioral symptoms. And these are not to the extent that they interfere with someone's ability to perform their daily activities. So that's the major distinction. They are, however, concerning to the patient and or their family members and or their doctor. Sometimes just some and not all of these, which makes things more complicated. But when patients ask me, what is dementia? I think it's a scary word in our culture, and people generally aren't so clear on what it means. The main distinction is that interference with ADLs. And so mild cognitive impairment, someone's daily activities are not impacted. Just as with dementia, to diagnose someone with MCI, you've got to see symptoms that are not explained by delirium or a psychiatric disorder. With MCI, we only need to see an objective decline in one major cognitive domain. So if somebody has difficulty with memory and everything else is fine, that's okay. As a general rule, about 10 or 20% of people with MCI will go on to develop dementia over each year. And of course, that's going to vary dramatically from individual to individual, depending on the cause of their mild cognitive impairment. For example, if someone has sleep apnea and a major thyroid disorder and you're able to correct those, they'll probably do a lot better than someone who's in the early stages of Alzheimer's disease or someone with every vascular risk factor in the book. So a question that we get asked a lot is, especially on the wards, is whether we're seeing someone with dementia versus simply delirium in the hospital. And as you know, delirium is extraordinarily common, especially in our older hospitalized patients. So I put together this chart just to highlight some of the typical differences between dementia and delirium. In the case of delirium, the onset is usually fairly acute, or at least subacute, and often it's in the setting of a clear metabolic derangement or an infection. Whereas dementia, most of the time, of course, there are rapidly progressive dementias, we'll see a much more gradual onset. In terms of the level of awareness, this can be a helpful distinguishing point as well. In delirium, we typically see a fluctuating level of awareness where someone may be quite lucid at times and much less with us at other times. In dementia, the level of awareness is usually fairly preserved, although we will see some fluctuations. A lot of patients' family members will say that they become less coherent in the evenings, the sundowning phenomenon, that can certainly happen. And in dementia with Lewy bodies, cognitive fluctuations are actually a defining feature of the disorder. So something to be aware of. But in general, the fluctuations are not so dramatic as we see in the case of delirium. Circadian disruptions are another helpful distinguishing factor. In delirium, these are severe and pronounced. And all of us who've worked night shifts have seen this phenomenon in action. In dementia, certainly patients will have sleep disruptions. They can be an important feature of the illness. In alpha-synucleinopathies like Lewy body, REM behavior disorders, where patients don't have the normal suppression of motor activity that we all have during REM sleep, are actually a defining feature of the illness. And certainly many demented patients struggle with sleep. We'll see issues of nighttime wandering and other nighttime symptoms in them. But the overall circadian rhythm is not so disrupted as we typically see in delirium. Hallucinations are very, very common in delirium, and I think all of us have also probably seen this on the wards. They're typically quite threatening, and patients can be very upset by them, very agitated as they experience them. In dementia, the early stages at least, we rarely see hallucinations in most dementia syndromes, except for Lewy body, where again, hallucinations are actually quite common and in fact a diagnostic feature. In Lewy body though, those hallucinations are typically non-threatening. They're also typically visual. So a patient may describe to you that they're noticing there's always a little boy in the bathtub, and they don't quite mind that he's there, but they just always see him. So it's a bit of a different emotionality to them.
Dr. Fredericks?
Yeah.
We've got our first question come across. Someone asked, how does major neurocognitive disorder differ from dementia?
That's a great question. And the basic answer is who's doing the diagnosing. So major neurocognitive disorder is the DSM equivalent of dementia. And typically our neuropsychologists, if they complete a formal evaluation on a patient, will define that patient's performance as consistent with a major or a minor neurocognitive disorder. In my experience, they're essentially equivalent, only the neuropsychology and psychiatric approach is based more specifically on cognitive performance and ADLs. The definition is essentially the same. And getting back to where we were in terms of delirium and dementia, one thing that is important to note is that these two phenomena interact. So a patient who is demented or on their way to dementia who ends up in the hospital for a hip fracture is far more likely to be delirious than other patients would be. And so you will often see patients with dementia who are also experiencing delirium on top of their dementia. Patients with Lewy body in particular, and Lewy body kind of keeps coming up here, are especially vulnerable to delirium. And oftentimes I find that patients who come in for an initial diagnosis of Lewy body, the family will first have become aware that something was off when their loved one was hospitalized for a reason completely unrelated to any cognitive symptoms. And experienced a severe delirium in the hospital and never quite got better. And as they settle back to their new baseline, they continue to have some of these disrupted sleep symptoms, some of these hallucinations. So these interact in complex ways. To move on and talk a little bit about the clinical diagnosis versus the pathologic diagnosis. One of the single most common questions that I get in the clinic from patients when I'm describing to them what's going on with their loved one is, so what's the difference then between dementia and Alzheimer's disease? And I think this is a more complicated question than it should be just because of the way the language around these disorders has evolved. And the answer, by the way, to that question, what's the difference between dementia and Alzheimer's disease, is that clinical Alzheimer's disease is the most common cause of dementia in someone over 65. We talked about what dementia is. It's basically that distinction about someone not being able to carry out their ADLs in the face of their behavioral or cognitive symptoms. But it's even a little more complicated than that because there's the clinical syndrome of Alzheimer's disease, which we'll talk about in a lot more detail shortly, but basically involves typically memory predominant symptoms that slowly get worse over time. And then there's Alzheimer's, the pathologic entity that we've all studied in medical school, where we see amyloid plaques, we see tau tangles, but that diagnosis can only be made with absolute definitive precision after someone passes away. So typically with Alzheimer's, the clinical syndrome is caused by Alzheimer's, the pathology, which can be understandably really confusing for patients. Sometimes we'll see Alzheimer's pathology that's focused in another system of the brain causing symptoms that are language predominant or spatial predominant. Sometimes we'll see a clinical syndrome that looks for all the world like Alzheimer's disease, but will turn out to be a different pathologic cause. And so I think it's important to distinguish for the patient whether you've made a clinical diagnosis that yes, your syndrome is consistent with a likely mild Alzheimer's dementia versus a pathologic diagnosis. And these days we have some intermediate biomarkers that let us assess, is there abnormal amyloid and tau, for example, in the spinal fluid, or are we able to see abnormalities on a targeted PET scan? And those can give us a better sense of what the likely pathology is while the patient is still living. But we need to be clear about distinguishing these two aspects of the diagnosis. In other dementing illnesses, the distinction between the clinical syndrome and the pathologic diagnosis can be far more complicated rather. So for example, in behavioral variant frontotemporal dementia, which is a syndrome that we'll be talking about a little bit later, the underlying pathologic cause can be any of a number of pathologies, mostly related to tau and TDP protein accumulations. So this is a beautiful chart that Bill Seeley at UCSF put together that illustrates a number of clinical syndromes of less common dementias. Behavioral variant frontotemporal dementia is the one here, and I hope you can see my mouse here. So these are the clinical syndromes at the top, and at the bottom we see all the pathologic entities that can cause those syndromes. So you can see the behavioral variant frontotemporal dementia, the clinical syndrome, can be caused by a number of tauopathies, including Pick's disease, a number of 4-repeat tauopathies. It can be caused by the TDP43 pathologic protein. It can be caused even by less common causes. Sometimes we'll even see a behavioral variant frontotemporal syndrome that's caused by underlying Alzheimer's pathology. So it gets quite complicated. And as you can imagine, this is an issue as we try to develop clinical trials in an effort to get better treatments for these illnesses. So the take home here is that ideally, you want to be able to give the patient at least a clinical diagnosis and a probable pathologic diagnosis, or at least be aware of the distinction between the two. So if I can tell you that clinically speaking, you've got behavioral variant frontotemporal dementia, I may not be able to tell you if it's a tauopathy or a TDPopathy, but at least I can be clear on the information that I am giving you. Let me know if all that makes sense so far. Otherwise, we'll move on to the main part of the talk and start focusing in on Alzheimer's disease, vascular dementia, Lewy body, and frontotemporal disease. So just a quick overview. Alzheimer's is the most common dementia syndrome over the age of 65, and the one that I think a lot of us know the most about, or at least have experienced in our own lives. Vascular dementia is arguably the second most common in older people. I remember being taught as a medical student and even beyond that it was a stepwise illness. That's really not true most of the time in my experience. It's useful in some ways, but oftentimes it's a more gradual decline too, which can fool you. I see a hand up. Do you want, Dr. Weber, should we take a question? If not, I'll move on. Lewy body disease is also extremely common in older individuals and has a lot of prominent psychiatric and motor features that we'll discuss in detail. Behavioral variant frontotemporal dementia is probably the most common dementing illness in individuals under the age of 65. And social and emotional function are probably the hardest hit cognitive domains. So I'm going to give you some vignettes for each of these illnesses. The idea is not to give you kind of a zebra or anything confusing, but really give you a very typical clinical presentation of each of these 4 illnesses. So in the first case, I'm going to tell you about a 70-year-old woman. She was a teacher. She recently retired. 2 years ago, she noticed that it was a lot harder than it had been for her to learn her students' names. She was one of those amazing teachers who would just quickly get 120 names for her 4 classes by the end of the first week of school. She also noticed she was relying more on her teaching notes in class. And she just started feeling a lot of anxiety and started seeing a psychiatrist for anxiety for the first time in her life. She'd had an episode when she was driving home from a friend's house, and she'd been there many times before, and she got lost on her way home. So she called her husband in a panic, and they decided that it was time to see a doctor and figure out what was going on. So in my office, and by the way, all of these are actual cases, usually kind of combined with some details changed for patient privacy. In my office, she was very socially appropriate. She did tear up a couple times describing her concerns about what her symptoms might mean. And I noticed when she gave me the history, she told me the same story a couple times, like the story about driving home from the friend's office. And that when I asked some historical questions, like, oh, how long ago did you stop working as a teacher? She would look to her husband to provide some of those details. She is someone who always took care of the finances for her household, balancing the checkbook, paying the bills, but she had started missing some payments and double paying others. And so her husband had taken over those bills for the last few months. I gave her the MoCA as an initial cognitive screen, and she struggled especially with recalling that list of 5 words. And if you can remember the 5 words there, a lot of patients with Alzheimer's disease, by the time you get back to the point where you're asking them to remember the 5 words, they may not even remember that you've given them the list in the first place. They'll start trying to remember F words, which is another thing that you ask for in the middle, or they'll just be puzzled when you ask for it. It's very different for a patient who initially thinks they can't recall any of the words, but then as soon as you give them a hint, like one of them was a type of fabric, they'll say, oh, velvet. And that suggests to me that that memory is there, but they need help getting to it. Whereas in a pure amnestic process like Alzheimer's disease, they may struggle with having encoded the words at all. So that's a fairly typical story for someone coming in with a mild Alzheimer's dementia. And her story illustrates some of the more common symptoms that we'll often see at onset. Short-term memory loss is, of course, a big one. Patients will tell you they're forgetting the details of recent events. They are losing track of important objects. They left their purse in the shopping cart again. Their family members are often the ones who realize what's going on when they start hearing the same question or story over and over. Patients, yes.
In a case like this, with the emotional overlay that's also common, how would you go about separating out a possible pseudodementia, and would you consider treating the anxiety before making the diagnosis of Alzheimer's?
Yeah, that's a really great question, because my opinion is that the anxiety that we often see early on in these cases is probably a part of the disease process. A lot of my research focuses on whether as memory networks that support our ability to form short-term memories sort of fall apart in the early stages of Alzheimer's, it may be that some networks that support emotional perception actually become hyperconnected, which could be part of why patients are feeling so anxious. Or we might imagine that simply being aware that they're having struggles with memory could make someone anxious simply because of that insight. And as the questioner is alluding to, of course, we want to make sure that the cognitive symptoms are not simply caused by the anxiety rather than the other way around. Formal neuropsychological testing can be really helpful here, as can careful history taking. Patients with anxiety can certainly have difficulty with attention, with multitasking, with staying organized. It's less likely, though, that they would have a true amnestic process where they really can't encode and retain new information. That would be much more of a red flag. So if you can get that distinction, if you can be comfortable with that distinction, either based on your own testing in the clinic or by referring for neuropsychological testing, that can really help. Regardless, I think many patients would benefit from early treatment of their anxiety.
Got another one if you're ready for it.
What's that?
Coming. Lots of questions for you.
Great.
If there's someone who's asymptomatic and you happen to just be doing a screening test and they fail to remember the 5 words, are you concerned about that at all? Or would you attribute that to possibly normal aging?
Yeah, it's a good question. And I think maybe all of us who have administered the MoCA can relate to that moment where you're like, wow, would I just totally blank out and not remember any of these? And I think certainly failing a simple test like that on one occasion is not in itself cause for concern. But if perhaps earlier in the interview with this person who had no memory complaints, they told you the same story twice about, how they twisted their ankle or, whatever they're in there for, that kind of context would be helpful. I certainly wouldn't, make a diagnosis based on those 5 points of the MoCA, but I would try to probe a little bit more, look at their performance on the rest of the test, think about their presentation, ask their family member if they're with them, if they've noticed anything. And, it would never be a bad idea to resort to more formal testing if you're not quite sure if this is a meaningful change you're seeing on your screening. And by more formal testing, I mean probably neuropsychological testing first, if you're truly not convinced of a concern. Good. So in addition to memory symptoms that we'll see pretty early in illness, we often also will see trouble with problem solving and multi-step processes. So some executive changes early. Patients might struggle to follow a recipe that they used to know by heart, forget which step comes where. They might struggle with using the remote or other common household appliances. They might get lost on familiar routes, as our patient did. They often will notice difficulties with word finding, especially for names of acquaintances they haven't seen in a while. They'll report to you that they kind of get lost in conversations. So all these things are common early symptoms. The Alzheimer's Association has a number of wonderful resources that you can have around in your office for patients. I think this chart is a helpful one in terms of patients who want to know, how do I know if this is just a normal age-related change versus the beginning of something like Alzheimer's disease? And this alludes a little bit to the previous question as well. And of course, all of us have cognitive changes as we get older. Many of us have probably even noticed that the progressive sleep deprivation of residency leads to a decreased working memory span. You might have been able to remember that entire medical record number without checking at the beginning of intern year and then find that by the end, it's hard to get those 8 digits. So typical age-related changes can certainly happen as we get older. Some of the most common ones are initially forgetting a word or having that tip of the tongue phenomenon where you can't quite get the precise word you want right away and then it comes back to you. Other things that we often hear are, I walk into a room and I just can't remember what I went in there to get. That's happening more to me. And then that's often a typical age-related change. So it's all about the context, the pattern, the severity. So just to kind of sum up, Alzheimer's is a clinical syndrome like we talked about, often caused by Alzheimer's pathology. And it's defined by dementia, so this functional decline. It's not typically an acute onset. You see a cognitive worsening. And the most prominent cognitive deficits are typically in one of these 4 cognitive domains, memory, of course, being by far the most common. We often will see patients in my clinic where the most prominent complaint is a language complaint, that someone's having trouble getting their words out, trouble naming. And that's by far the most disturbing symptom to them compared to language. And that may indicate that you're seeing one of these less common variants of Alzheimer's disease, the non-amnestic Alzheimer's syndromes. You can see spatial predominant Alzheimer's disease, a syndrome called posterior cortical atrophy. You can also see the so-called frontal variant of Alzheimer's, where executive difficulties are the most predominant. But again, memory amnestic Alzheimer's is by far the most common form. I think the number is officially something like 5% or 10% of Alzheimer's presents in this non-amnestic way. I suspect that number may be a little bit low, simply because many patients, for example, who have a visuospatial variant will have the feeling that something's wrong with their vision. So they'll go to their ophthalmologist, they'll undergo some significant workup. By the time they reach neurology, they may have prominent language or memory symptoms too. And then it's more difficult to tell that this was a non-amnestic presentation.
Why, hello again.
Hello again.
So I don't know how much you're going to address this later in the talk. We've got some questions popping up about treatment.
Yeah.
You're going to hold those for now. Are you going to address like cholinesterase inhibitors and things like that later? Or
yeah, we'll talk about that in just a little bit.
Okay. There was one other question about differentiating functional neurologic disorder with cognitive complaints from a dementing illness like Alzheimer's, for example.
Oh, yeah.
How you might go about doing that, what the best process you would recommend.
Yeah, that's a good one. I think, all of the neurologic subspecialties have our cohort of patients who have a functional etiology to their illness. And I think in these cases, I lean heavily on my neuropsychological colleagues because they're able to incorporate metrics in their testing, like effort testing and other measures to get a sense of whether, for example, someone is really struggling with a very basic test that most patients with a moderate dementia would do well on, and then performing better on a test that's more complicated. So that kind of careful testing can be extremely helpful. It's also helpful to understand the trajectory. So if someone is having symptoms that are clearly objectively declining over time, I'm much more concerned than if their symptoms are sort of patchy in terms of objective testing and relatively stable over time. It's always complicated because, as with other functional disorders, you can have someone who's got some functional overlay but truly does have a cognitive syndrome. So we have to be careful about that.
I think this one's a bit of a throw out to me, or a shout out to my team anyway. Do you ever use the SLU mental status exam?
Oh.
What would you say is the difference between the MOCA and the SLU? And I won't have my feelings hurt if you say one's better than the other.
The fact is that I've seen the SLU reference before, and I just am not personally as familiar with it. But I think that's much more about, where I happen to do my training and stuff than any objective valuation or of the respective tests' merit. Do you want to say a little more, Dr. Weber, about the SLU?
Unfortunately, I do almost no dementia work, so I don't remember. I haven't used a SLU since residency, a slum since residency, so I don't really remember how it differs. I use MOCA.
Sounds good. I was wondering if I had some.
In my clinical practice, I just use MOCA because it's easily available to me.
Yeah.
I'm sure the slums is great from what I remember in residency.
All right. And, so these are the basic clinical criteria defined by McCance et al. In 2011. And if you look at just these and how they do in terms of our real world ability to diagnose these patients, they're pretty sensitive. So you're not going to get a lot of false negatives, but understandably, they're not so specific. So we'll see a lot of false positives if we simply define Alzheimer's disease this way in terms of the actual underlying pathology. The subspecialty clinics that can take the time to do a very, very detailed, lengthy evaluation of these patients do quite a bit better, but still are only accurate about 90% of the time. This is something that's changing a lot in the Alzheimer's field in recent years, as we're able to incorporate biomarker data from PET scans, from spinal fluid testing, to give us some objective evidence of whether there's underlying Alzheimer's pathology. So the updated McCance criteria also have a piece that incorporates biomarkers. So for example, if I had a patient who clinically has probable Alzheimer's dementia, and I've also done amyloid PET or amyloid spinal fluid testing, and they're positive, and I can also tell from their structural MRI that there's a bunch of atrophy in the hippocampus or that their spinal fluid tau is abnormal, I can now say that I have, high evidence of the Alzheimer's pathophysiologic process for that patient. So this is a little bit more helpful, especially in terms of finding patients who may be good candidates for clinical trials if they're interested in that, or otherwise conveying how sure we are of this diagnosis. Same thing for MCI. So based on the most recent clinical criteria, I can also say, yeah, this person has mild cognitive impairment and there's a high likelihood it's due to Alzheimer's disease because, hey, I got their CSF amyloid and tau and they're both abnormal. In terms of structural imaging of Alzheimer's disease, as I'm sure you all know, the characteristic features are atrophy of the mesial temporal lobes and especially the hippocampi. You can see a nice example of that here. There's also typically a lot of atrophy in the parietal lobes. And these findings are supportive, but not diagnostic. Similarly with FDG PET, so glucose imaging, we can see some decreased avidity in the mesial temporal lobes and lateral temporal lobes and also in the parietal lobes. I've asked myself this question here because if you'd like to, I'd be glad to talk about how these areas are part of a network called the default mode network that seems to play a really important role in supporting short-term memory. And it seems that Alzheimer's pathology, at least in amnestic Alzheimer's, seems to really target this specific network. And so that's probably why these are the areas that sort of atrophy together, that show decreased glucose use together, and that may accumulate tau together as well. Amyloid and tau. We've all talked about amyloid and tau probably at length in neuropathology courses in medical school. But just to review, these are the two key pathologic features of Alzheimer's disease. Amyloid accumulates into these neuritic plaques. Here's a nice one, or a bad one, I guess, depending on how you look at it in the middle of this slide here. These are extracellular deposits of amyloid, and they also include some damaged neurites and some evidence of local inflammation, so microglia surrounding reactive astrocytes that will stain positive with GFAP. We also will often see these diffuse plaques. They're not diagnostic, but also present often in Alzheimer's disease that are made up of filamentous amyloid and that don't have those other inflammatory elements and damaged neurites. Neurofibrillary tangles, here's a nice one over here, are made up of intraneuronal hyperphosphorylated tau. That's the other pathologic hallmark of Alzheimer's disease. And the story of how these two pathologic proteins interact in Alzheimer's is a complicated one, and one that there's been a great deal of argument about in the field that's ongoing, frankly. Cliff Jack and colleagues made a figure that I think is really helpful describing the changes that we notice in patients who are on their way to Alzheimer's disease over the course of their being cognitively normal and then descending into MCI and dementia. Where amyloid scans, like amyloid PET, will pick up abnormalities quite early in the course of illness that will increase over time and then be at their peak really close to the time that someone is still cognitively normal, so quite early. A positive amyloid scan usually predicts, if you can catch the first moment that it turns positive, that someone may develop Alzheimer's in 10 or 20 years. So it's quite early on. The belief in the field has been that tau-mediated neuronal injury happens a little bit later in the course. It's starting before someone shows clinical symptoms, but it seems to happen after amyloid accumulation has clearly become pathologic. And there's some argument about that, especially in terms of very early stage tau and how very early stage tau in the brainstem, like the locus coeruleus, may spark the further accumulation of amyloid. So that's, again, somewhat up for debate. In terms of structural atrophy, that seems to follow amyloid and tau pathology. So we may not see atrophy on MRI that's meaningful until the patient has a pretty significant amount of amyloid and tau pathology. Memory symptoms are still later, so by the time we have a patient who comes to us with clear memory deficits, the pathology is probably well on its way. And clinical function, of course, lags even behind someone's memory complaints in terms of their ability to do their day-to-day tasks. So why is this important and why is this a problem? Well, it has a lot to do with clinical trials that are being designed currently. For example, it may be that somebody who is clinically diagnosable with MCI or dementia has so much brain pathology at that point that it's going to be really challenging to design a therapy that can reverse that. Whereas if we were able to identify patients at this stage, perhaps interventions could be more helpful. So that's an area of a lot of active ongoing investigation. There's this very typical march of tau pathology across the brain in amnestic Alzheimer's disease. This is a figure from an Arnsten et al. Paper based on the Brock and Brock staging that Brock and Brock published back earlier this decade. But essentially, the tau pathology seems to start in the brainstem in the locus coeruleus, then spread into the entorhinal cortex, and from there into hippocampus, and then across the brain more broadly, only in the later stages of illness. And again, I think there's a lot of debate in the field. And my understanding as a resident was that amyloid and tau interact in this way such that amyloid is more diffuse throughout the brain. And once you get a certain level of amyloid buildup, the tau gets released and it can sort of spread out of the entorhinal cortex and go all over the brain. And that's when you get significant symptomatology. That's still generally true, but again, there's a lot of debate now in the field over whether early stage tau is somehow driving amyloid to accumulate to that pathologic level, versus whether amyloid is just sort of letting the tau out of the bag. We, in recent years, have had access to a lot more clinical tools to get a sense of amyloid and tau in the living brain in our patients. The top figure is looking at spinal fluid data, looking at various combinations of spinal fluid amyloid, total tau, and phospho-tau, and using those to try to help us diagnose basically in vivo, does someone have abnormal levels of Alzheimer's proteins? Probably many of you have sent these tests. I think Athena and Mayo are both offering them now, and they're quite good. For most patients, they can give us a low 90s sensitivity and specificity if they, in terms of their ability to identify whether someone's amyloid and tau levels are consistent with Alzheimer's disease or not. So that's a clinical tool that's really come into common practice just in the last decade or so. Amyloid PET is not currently available clinically, but is just about as accurate in terms of giving us a sense of whether someone has Alzheimer's pathology driving their symptoms. And as you can see here, here's a control patient and a patient with Alzheimer's looking at the amyloid tracer. And you can see that the brain just lights up with abnormal amyloid in the Alzheimer's patient compared with the control. These are the typical findings from a normal glucose PET, and you can see it's a little subtler, but the Alzheimer's patient has a significant reduction in glucose metabolism in the parietal lobes that you don't see in the control who has healthy metabolism throughout. More recently, we're looking at ligands that can bind to tau. And tau pathology seems to, again, spread in this very characteristic way. So abnormal tau allows us to stage the illness in a way that amyloid doesn't. Amyloid's kind of a plus minus thing as far as we interpret it these days. You can see here that in this tracer that binds to tau, in a healthy control, there's very little binding, perhaps a little bit more in the temporal lobes than other places. In mild cognitive impairment, it becomes very clear that there's abnormal tau in the mesial and lateral temporal lobes, and in Alzheimer's disease, there's still more accumulation there. So that's currently just a research tool, but a very promising one, especially in terms of our ability to monitor how well we're doing with clinical trials. So to get back to your question about treatment and back to our patient, first of all, what kind of workup does she need? Are we just going to say, clinically, this is Alzheimer's, here's, let's start you on a medication, or is there anything else we need to do? And the AAN's answer to that is, there are a few things you should do. We should send a B12 and a TSH. Those are actually the only evidence-based labs that you need to send. Some of us have been taught to try other things. I would certainly send an RPR, especially if the person has risk factors for syphilis. Using these tests, about 9% of the time, we'll find some partially reversible contributor to dementia. So perhaps their thyroid is a little off, perhaps their B12 is quite low, but only in 1 to 3% of cases will we find a fully reversible cause. Imaging is recommended, either head CT or an MRI. That's essentially just to rule out a completely different cause, which is uncommon. But of course, the MRI especially can also give us a lot of other hints as well. You'd want to do some sort of depression screen to rule out a pseudo-dementia, get some neuropsychological testing, simply to confirm for yourself this person does have objective memory loss, rather than just a subjective feeling that their memory is affected. The current guidelines don't recommend additional testing of the sort we've been talking about, but I think this is on its way to changing, especially given the new diagnostic criteria that incorporate these, probable AD pathology based on biomarkers. The other helpful thing about imaging I wanted to remind myself to tell you is that if someone has a really heavy burden of white matter disease, that can be pretty suggestive that there might be a vascular component to their presentation. And oftentimes vascular illness and AD will coexist. So many of our patients have many comorbidities. It is pretty rare, though, to find an unexpected tumor or something like that in someone who comes in with a very typical amnestic presentation. So in terms of treatment.
Yes. Quick sec. On the diagnosis end, is there anything from those clinical tests or the neuropsych testing that would have you staging the severity of the dementia itself, like the mild, moderate, severe sort of Alzheimer's disease?
Yeah.
I get that question from patients a lot, is how bad is my Alzheimer's? Or I did back when I saw them.
Yeah, that's a great question. And I think there are some scales out there that will actually give you, like a stage 1 through 9 kind of finer grain. In my own practice, I will typically stage, certainly distinguish mild cognitive impairment and dementia. And then I'll stage mild, moderate, and severe dementia based entirely on activities of daily living. So if somebody is, still functioning at a pretty independent level in many ways. So for example, they're really struggling at work and they've asked their spouse to start double checking them with their bill pay, but otherwise they're fully capable of doing most of their day-to-day activities. I'd put that in the mild dementia category, whereas somebody who is struggling with basic ADLs, like toileting, feeding themselves, is more on the severe end of the spectrum. And obviously this is not at all a fine-grained distinction, but I find that kind of mild, moderate, and severe is really more helpful in terms of what we need to be thinking about in terms of resources, in terms of planning for the future, and in terms of medications than any finer grain is. And that patients vary so much in how quickly or slowly they progress that, a number is honestly not as meaningful clinically. But people disagree about that. And some of my patients, would really like a much more precise indicator of where exactly they are. Neuropsychological testing can certainly give us that, more so than serial MRI, for example. If your hippocampus is 10% smaller this year than it was last year, that doesn't actually tell me much about where you'll be 2 years from now. Whereas if I learn that your delayed memory testing performance is, another standard deviation lower, that makes me much more concerned.
In your clinical practice, when would you consider doing some of those other tests that aren't necessarily recommended by the guidelines outside of research? Because I know you run a lab, but outside of that, just clinically, when would you say do the lumbar puncture, for example?
Yeah, the lumbar puncture is the one that I probably do the most. And I'll use that especially in patients where, for whatever reason, I'm not confident of the diagnosis, or they're in a group that is less likely to have the diagnosis. So most of my patients with early onset Alzheimer's disease, I will want to confirm the diagnosis. If you're 55, even if it looks for all the world like AD, I'd like to know that for sure. If the presentation is much more rapid than I would expect, spinal fluid is nice because I can also do some testing for rapidly progressive dementias for any evidence of inflammation. Or if somebody just has kind of a funny mix of features, there's some things that look a lot like Alzheimer's, but they're having some Lewy body-like features, or they do have a history of a lot of vascular illness. It can be nice for teasing those apart. It's tough because in a way it doesn't change your management a lot, unless it's somebody where Aricept would really be a game changer, and Aricept is typically not a game changer, as we'll discuss. But I think, for a patient who's interested in clinical trials, or again, for a younger patient, where this is going to have big implications for their family, for their lives moving forward, where I really want to be sure, that's when I'll do it. In older patients, mostly if they're interested in drug studies. This is a little chart I made kind of reviewing some of the common treatments that we use across the board for different kinds of dementia. And I know we're actually getting towards running out of time. And so this may be more of an Alzheimer's talk, but we'll see where it goes. I'll try to get through some of the other ones as well. But I appreciate all the questions. Acetylcholinesterase inhibitors, Aricept or donepezil being the most common, but we also use rivastigmine or Exelon a lot, and also galantamine sometimes. Their role is to slow clinical decline in dementia. This is mostly based on evidence that if you look at large groups of people who are on or off these medications, the ones who are on will generally do a little better on cognitive testing after a 6-month or year-long interval. So this medication, or this class of medications, is approved by the FDA for Alzheimer's dementia, not MCI, interestingly. I also find it really helpful in Lewy body, which we'll talk about more when I get to Lewy body disease. I will prescribe this medication fairly often in mild cognitive impairment personally, if I'm convinced that there's underlying Alzheimer's pathology. I won't if I'm not sure, but clinical practices vary a lot in that sense. These medications will cause mild GI effects. Sometimes I find that just anecdotally, patients who have difficulty with taking the Aricept pill in terms of GI effects will do better with an Exelon patch. And I know others have had that experience as well. Mementine is an NMDA receptor antagonist, and that's one that seems to slow cognitive decline only in the later stages of dementia. So the FDA has approved that for moderate to severe Alzheimer's only. Some clinicians will prescribe that pretty early because, why not? It's pretty benign. Most people tolerate it well, although there is, the risk of dizziness or headache or GI side effects. My typical practice is not to prescribe it until later in dementia. I just haven't seen it change that much for people earlier than that. But again, people vary. Melatonin, we can talk about a little bit. Yes, Dr. Weber.
Did you say you would prescribe the acetylcholinesterase inhibitors in mild cognitive impairment if you thought there was Alzheimer's pathology? Okay.
Yeah, and that's my practice. I just, my sense is that, the acetylcholine effect, if it's going to work once you're sure it's Alzheimer's and they're a little more demented, it makes sense to me that that boosting that chemical in the brain might also be helpful if you're sure that's the cause of the MCI. Yeah. My gut is that MCI studies have been negative in part because there's such a variety of causes of MCI. So like if you have a thyroid disorder and I give you Aricept, it's not going to do anything, but that doesn't really mean much. Sure. Mementine I'm less convinced of, but some people will prescribe it in MCI and swear by it. So.
Do you usually go for a couple acetylcholinesterase inhibitors before switching to Mementine, or is it just based on the severity of the dementia in your practice?
In my practice, I'll have them on one acetylcholinesterase inhibitor, and then I'll add on the Mementine once they're a little beyond that mild dementia stage. So it's typically in addition. Melatonin I really like. It's super benign. It's, of course, a natural hormone that regulates our circadian rhythm. At a very low dose, like 0.5 milligrams before bedtime, it can help sort of encourage a healthy sleep cycle in our older patients with Alzheimer's and other dementias, just in the sense of kind of telling the body to cool down and slow down in the same way that it works for jet lag for the rest of us. At higher doses, like above 10 milligrams a night, it can really suppress REM behavior disorder quite well, probably as well as clonazepam overall, although some people respond better to one or the other. And certainly with fewer cognitive side effects than clonazepam. So that's one that I use a lot in my Lewy body patients. The other things on here are not medications per se, but we do have some evidence that significant cardiovascular exercise, so 150 minutes weekly of a moderate intensity cardio regimen. And I'll tell my patients that's like, if we were going for a walk together, we could still talk, but we'd be a little out of breath. That's moderate intensity. That seems to slow down cognitive decline and reduce the risk of memory loss, at least in healthy aging and MCI, and probably in dementia, although the evidence is not as strong there. Same thing for a Mediterranean diet, for staying cognitively active. We can talk in more detail about those things later if you like. I'm going to move on to vignette number 2, unless there's any more Alzheimer's questions at this point.
One more.
Yeah.
For a patient with mild cognitive impairment who claims to be fine, but the family's very concerned, how often do you follow them up? What sort of testing might you do? Or you just see them back as needed for worsening?
Oh, that's really tough. And a lot of dementia care it's almost like pediatrics in that you're kind of managing a family dynamic. And sometimes patients will have a lot of insight to the point where it's painful, and other times they'll lack some insight to the point that you're worried. I've definitely had patients, for example, where I'm convinced something is wrong, so is the family member, the patient is not, and the family member is like, can I take away their keys? And those kinds of questions get really high stakes, because you don't want someone to realize they can't drive after something terrible happens. In some states, of course, there are mandates about when you need to report stuff like that, and others there are not. But I think to try to answer your question more generally, I like to keep close tabs on patients like that, and I think often they do respond well to my saying, I am a little concerned. I'd like to follow up with you. Let's have you come back for repeat testing in a few months, even if it's not going to be formal repeat testing. And I think then kind of working with the family as well to think about, what do we need to do right now in terms of safety measures? It can be very tough. Often I think family members are sort of shocked to visit a more distant family member and realize that the finances are in disarray, the fridge is a mess, and the person has never said anything is wrong and they couldn't tell over the phone. So situations like that can be very hard and kind of require a multidisciplinary approach. I err on the side of pushing hard for driving evaluations because I've seen a couple of cases where something terrible has happened, and we certainly don't want to risk that. I'm kind of a mind to skip over this second vignette, which is a vascular story, because I think this is maybe less interesting than Lewy body, given that we only have probably 10 more minutes, or maybe even need to stop earlier for questions. So I'm going to jump to Lewy body disease. And perhaps I can come back and do vascular and FTD. Okay, so here's a Lewy body story. This is a 70-year-old man. He's an attorney. Everything was fine. He's on a trip to Asia with his wife. And then he began experiencing these very vivid nightmares and acting them out in his sleep, to the extent that she had to sleep in a different bed. She'd maybe noticed this a little bit before, but never to this extent. She wondered if it was just jet lag or something weird about their trip. Then they got home and he told her that there was a little boy in their bathtub. That's where I got that example before. And that every time they'd go for a walk, he'd see this Civil War soldier, all dressed up in his gear, pacing in this one neighbor's yard. When his wife was thinking back on, was there anything before this that I'd missed? She had noticed that there were some funny near misses when he was driving. It seemed like he wasn't able to judge distances and turns as well on the road. So they'd be making a left turn and he'd be kind of like over the line. And she'd, blame it on his being tired, but in retrospect, it was probably a pattern. On his neurological exam, there was some cogwheeling, especially with augmentation just on one side. There was some slowing and decreased amplitude of fast taps on the same side, so a little bradykinesia, and a slightly shuffling, stooped quality to his gait. So essentially mild Parkinsonism, maybe a little asymmetric. On the MoCA, he struggled with the cube copy, and both his cube and clock copy were quite small. So again, it's a suggestion of some Parkinsonism and some micrographia and some visuospatial dysfunction. I'm showing you a figure from a test for Peridolia. All of you can probably see a face in this picture. This test has a number of images that look kind of like this, some of which truly have embedded faces and some don't. Patients with Lewy body will also often see faces where you don't see any. In terms of diagnostic criteria for Lewy body disease, this is a dementia syndrome, so they meet clinical criteria for dementia, but memory is often affected pretty late. The earliest and most prominent deficits are usually in spatial function or executive function or attention. And in order to diagnose someone with probable Lewy body disease, you want to see at least 2 of these 4 major features, or if you have supportive biomarkers, perhaps 1, and we'll get into that. But the 4 key features are fluctuations in cognition. So the family will kind of notice, someone's, for an hour or 2, he'll just be kind of staring. He'll be vaguely watching TV and he'll kind of have to work to get his attention. And other times he's more lucid. Visual hallucinations of the sort we described around behavior disorder, and 1 or more of the cardinal features of Parkinsonism. So something similar to what I described in this patient's vignette is quite common. There are also other clinical symptoms that are supportive of the diagnosis, so not part of that kind of group of 4 core features. For example, a severe sensitivity to antipsychotics. Sometimes these patients will come to our attention after getting Haldol for delirium in the hospital and responding with extreme motor side effects or paradoxic agitation. We'll see episodes of syncope or postural instability or transient episodes of unresponsiveness, probably a reflection of this illness's effect on the autonomic nervous system. We can see severe autonomic dysfunction in other ways. And often we'll pick up stuff like, erectile dysfunction or other, milder autonomic symptoms if you ask. Patients will often have hypersomnia, hyposmia, so these other sort of more neurovegetative symptoms as well. In terms of biomarkers that can be helpful, everyone varies a lot in terms of how often they will do a DAT scan. I hadn't used them too much in my practice, and I'm starting to incorporate them a little bit recently. But of course, this is a dopamine transporter scan. And if you examine someone with Lewy body, you'll see that there's less uptake of dopamine in the basal ganglia as a result of loss of those neurons. So this is an example on the right, compared to a healthy person who has plenty of dopamine transporter activity, kind of lighting up those basal ganglia. You can also do an MIBG, a myocardial scintigraphy scan, and that in someone with Lewy body will show low uptake on that reflects that the sympathetic innervation of the heart has been disrupted by the alpha-synuclein. You can also get a sleep study and show that the person truly has REM sleep disorder. So all of those can be helpful biomarkers. Supportive biomarkers as well. Simply finding that the person doesn't have mesial temporal atrophy on MRI, as you would expect in Alzheimer's disease, can be helpful in making this diagnosis. We really lack, though, clear imaging biomarkers. Similarly, on PET scan, you can see that there's generally lower uptake than average kind of across the board. In particular, you might see that they have lower occipital activity. And you can see what's called a cingulate island sign, so that the posterior cingulate, which gets hit pretty hard in Alzheimer's disease, is relatively preserved in Lewy body. You can see EEG changes, in particular, especially prominent posterior slow waves. Although, again, that's not something we'll routinely order in Lewy body patients. And in Lewy body, all these imaging biomarkers can be helpful if you're confused or at a loss, but I think a good exam will typically point you towards an alpha-synucleinopathy, and a good history will typically help you pick up some of those core clinical features. And I find that I rely on those quite a bit in Lewy body patients. So Lewy body is an alpha-synucleinopathy. One of many neurodegenerative, not many, but several neurodegenerative disorders that are characterized by this abnormal accumulation of alpha-synuclein. Other ones that we often see are Parkinson's disease, MSA. And here's a Lewy body. It's a cytoplasmic inclusion made up of alpha-synuclein. That said, there are other inclusions, including smaller alpha-synuclein deposits at presynaptic nerve terminals. And those can really mess with synaptic dysfunction, and more we think that rather than the Lewy bodies, these big inclusions being the primary cause of symptoms, it may be that this disruption of synaptic transmission is the bigger cause of people's symptoms. Lewy body is fascinating to me. It's really common. It probably represents up to 30% of dementia in older people, but we really haven't studied it, certainly in the way that we've looked at Alzheimer's disease. There's no clear imaging biomarker. It's been really hard to develop a PET tracer, for example, because a lot of the binding sites for alpha-synuclein will also bind to amyloid. And so this has been a huge limiting factor for clinical trials. And it's an area of very active investigation. The silver lining of Lewy body. Acetylcholinesterase inhibitors, which I think they have a real but quite mild effect in Alzheimer's disease. They can really help folks with Lewy body. I've seen them essentially resolve hallucinations and cognitive fluctuations. These patients are quite sensitive to antipsychotics, and so often a low dose of Aricept will do so much more with much safer side effect profile than one of those more powerful medications. Melatonin will often completely resolve REM behavior disorder, although sometimes you have to push the dose to 15 milligrams to see that effect. And when patients are normalized in that sense, when they have a much more normal sleep rhythm, you'll find that they often do much better during the day as well. Some Lewy body patients respond to dopaminergic therapy for Parkinsonism. I have a few who are on low doses of carbidopa-levodopa and do great. But for most of these patients, those medications don't help so much. They also, of course, run the risk of worsening their hallucinations. Luckily, though, for most patients, those movement symptoms remain quite mild, especially compared to what we see in our folks with Parkinson's disease. Just to go back to treatment, I'm not going to belabor this because I think we talked about it quite a bit, but again, I'd use these acetylcholinesterase inhibitors a lot, sometimes at higher doses than I do in Alzheimer's disease in Lewy body, and then melatonin. I'm aware that we're just a couple of minutes from closing, so maybe I'll stop here and see if there are any questions before we stop for today.
You've been doing a pretty good job keeping up with the Q&A. I have just a practical question. Do you have any trouble getting approval for the acetylcholinesterase inhibitors in Lewy body patients?
I haven't, thank goodness. And I think it's because they're old and cheap. I think if I were trying to, if it were IVIG or something, it would be harder. Sometimes they'll push back on ribostigmine patches unless someone has officially failed donepezil, which can be annoying in a patient who has chronic GI issues and really doesn't want to take any increased risk of GI side effects. But yeah, that's usually no problem.
Can cholinesterase inhibitors also be used in Parkinson's disease dementia?
Yeah. So Parkinson's disease dementia and Lewy body are probably kind of on a continuum. The definition really depends on, which started first and for how long you've had prominent movement symptoms. But I think a lot of people feel that it's kind of a spectrum. For whatever reason, ribostigmine has been studied more in those populations and shown to be efficacious. Honestly, probably any of the acetylcholinesterase inhibitors are fine, but often we'll see Exelon used in this population for that reason.
Fair enough. And how important clinically is it to make a distinguish between DLB and PDD, and what tips would you give for distinguishing those two?
Yeah, I think it's honestly most helpful for consulting with the family. I think, typically in someone with PDD, the movement symptoms are going to remain kind of the most prominent and the most debilitating for them as they progress. And so the family will need to be ready. And they may also want to consider some, direct intervention in terms of DBS and those kinds of therapies for Parkinson's, as early as they can. Whereas someone with Lewy body, their movement symptoms are not likely to get that severe, but the family has to be ready for some significant behavioral and psychiatric symptoms and some more significant cognitive decline. So I think it's very helpful for people to kind of understand what's likely coming and to focus on the symptoms that are most likely to be a problem.
Any clinical tips on distinguishing RBD from other sleep-related movement problems?
Usually you really just need to get the spouse in the room or anyone who's in the room with the patient. And I think sometimes you'll hear things that are confusing, like, well, they kind of yell out in their sleep and they twitch a lot, but no, I don't think it's purposeful movement. And if it's really unclear, I'll just get a sleep study. But most of the time you'll get a pretty clear story from the spouse, like, yeah, like this one night he tried to strangle me and I woke him up and he told me that he was just dreaming about this person, who was intruding in the house. And so now I sleep in a separate bed. And like, that's about as pathognomonic as you can get. So usually you can tease it apart from the history.
Looks good. It looks like, well, the one last thing we can squeeze it in. Can DLB patients present visual hallucinations and MCI without Parkinsonism early in the disease course?
Yes. And I find that especially after hospitalizations and stuff like that, like sometimes we'll have patients who have what looks like kind of a standard delirium, except the hallucinations are more prominent and they never go away. I've seen that a few times. And so they'll continue to have these sometimes fully formed hallucinations and sometimes more this, there's a word for this that I'm blanking on right now, but the sensation of a shadow-like presence behind them. It's weird. You can ask people about this and they'll be like, yes, I have that. Like there's always this feeling like something's right behind me. So stuff like that can happen really, really early. And people often won't bring it up unless you ask because it's kind of a weird thing for people to experience and something that doesn't strike them as necessarily related.
Thank you very much, Dr. Fredericks. It's a great talk. I'll let Allison take over from here.
My pleasure. Thanks for having me.
Thank you, Dr. Fredericks. That was an amazing talk. Thank you, Dr. Weber, for being a really great Q&A moderator. And thank you to all the attendees for being engaged throughout the whole talk. Thanks for joining the third AAN Virtual Resident Education Lecture Series. These are recorded and will be available through AAN.com. I put the link in the chat to usually where we upload. Otherwise, you can check our YouTube channel. The next Virtual Resident Education Lecture Series is June 17th with Dr. Tracy Cho presenting on neuroinfectious diseases. So look for the Zoom link on the AAN social media channels. And thank you everyone for joining us today.